Hello, everybody. My name is Alexandre Marra. I'm a professor of the postgraduation Stricto Sensu program in health sciences at Albert Einstein Instituto Israelita de Ensino e Pesquisa, and also I'm a researcher at Einstein Hospital Israelita. I've been researching at the University of Iowa Internal Medicine Department in Iowa City, Iowa for over 10 years. I'm thrilled to introduce our international webinar series featuring guest speakers. This is the sixth presentation of the year 2026. The international webinar series is part of our global initiative with the postgraduate program designed to connecting Brazilian researchers, students, and healthcare personnel with international professors and researchers. It's my pleasure to introduce our guest speaker, Dr. Marisa Holubar. Dr. Holubar is an infectious disease specialist with a primary focus on hospital patient care. She is a national leader in antimicrobial stewardship, serving as the medical director of Stanford Antimicrobial Safety and Sustainability Program and co-director of WHO Collaborating Center. Dr. Holubar is deeply committed to the mentorship of trainees and junior faculty and currently serves as the senior vice chair of clinical affairs of the Department of Medicine. I've been honored to have Dr. Holubar here today, and it's been rewarding to collaborate with her on a couple of research projects. She'll talk to us about building a global alliance, the next generation of antimicrobial stewards. We have planned for Dr. Holubar to speak 35 minutes, and after this, we will have 15-20 minutes to open for answer questions. You can unmute yourself and ask your question after Dr. Holubar talk, or you can type your question in the chat. I'd like to ask for all of you to answer the survey at the end of the presentation. And thank you very much, Dr. Holubar. The floor is yours. Thank you.
Thank you so much, Dr. Maha. I think I'm really delighted by this invitation to join you. I've really appreciated the interactions that I've had so far with individuals at your institution, and I really firmly believe that stewardship, A, is a fantastic field, but also we're all in this together. So my instructions for this session was to talk a little bit about my pathway in terms of career development and what's been important to me. And then also to talk to you a little bit about antimicrobial stewardship in general. Okay. So my journey to a career in antimicrobial stewardship was not direct. I am originally from Green Bay, Wisconsin. Wisconsin is highlighted here in this map, very close to Iowa. I went to undergrad at University of Wisconsin-Madison and was the first of my nuclear family to graduate from college. I then went on to go to medical school, but that was at University of Wisconsin-Madison. And part of that was informed by the fact that during my time as an undergrad, I became very interested in microbiology. I went into undergrad without real designs on what I would do with my career and fell in love with science, although prior to that, I had been mostly interested in literature. During my time as a medical student in Wisconsin, and also some work in my residency, I really became very interested in health across borders. I spent time as an undergrad, as a medical student, and also then later as a resident. I was a med peds resident at Brown University in Rhode Island, in countries serving in Africa and in Central America. And after my residency, where I really was questioning whether I should do primary care, I decided to do infectious disease. Part of the reason that I decided to do that was I really loved clinical cases that were complex and involved multiple different organ systems. I liked being able to interact with multiple different um, teams at an institution. And I loved the idea that exposures could inform our differential diagnosis. After my residency, I spent a year at uh, a site in Eldoret, Kenya, working primarily in pediatrics, employed by University of Indiana, and working with a group called AMPATH, which was focused at that time in delivering HIV care and then eventually primary care to a large group of people in Western Kenya. And that was also a really formative experience for me in a lot of different ways. And one that in order to lift up an entire kind of community, it was important to look at the healthcare system as a whole, and also that there was so much more than the clinician-patient interaction that really um, led to health and prosperity for an individual and a family. I then finished my fellowship at Stanford. Came in 2010. I worked in a lab like many people do as infectious disease fellows, and I also got a master's in epidemiology. And towards the end of my training, I was really not unsure of what I would do next. And at that time, I felt like there were so many options. And I feel like this is one thing I'd love for you all to, um, maybe I'm preaching to the choir, as we say in the US. You all know this already, but there are so many really interesting and fulfilling careers within medicine, but definitely within the fields of infectious disease. It's really astounding. My experience as a mentor is that this, in some point, uh, in some ways paralyzes trainees because they think that they have to make the right decision right after they finish training to have this amazing career. And in truth, I think that the ones that kind of sway back and forth and change are actually even more interesting. So at the end of my fellowship, though, I was fortunate in that many different institutions were looking for people interested in leading antimicrobial stewardship programs. And antimicrobial stewardship is fundamentally defined as coordinated actions that promote the optimal and responsible use of antibiotics. And the reason this is important is that it helps to keep patients safe. And of course, is one of the major ways that we actually have control of in terms of combating or slowing the emergence of antimicrobial resistance. If you'll pardon, I'll just give you a little history here. The term stewardship was actually first used in publication in 1996 when it comes to antimicrobials. So it's a relatively young field within medicine across all of our different countries. And this was the first paper published by some hospital epidemiologists and infectious disease leaders in the US that suggested this term of antimicrobial stewardship. And original efforts to control antimicrobial use started with infection prevention programs. So there's a lot of places where um, the two programs, antimicrobial stewardship programs and infection prevention programs, are really quite intertwined in terms of their day-to-day work. And this really came from this idea that there was antimicrobial resistance occurring in hospitals. There was a lot of concern about methicillin-resistant Staphylococcus aureus infections at that time, and that there was more than infection prevention methods that were necessary. Instead, we really needed to start to control or rein in indiscriminate antimicrobial use in order to prevent the emergence of antimicrobial resistance. Early stewardship interventions in many different institutions, probably yours in addition, really relied on an existing pharmacy infrastructure. So this idea of physical and therapeutics committees started in the 1930s in the US, and this was all based on trying to control the types of medications that were being used in hospitals. And so a lot of the early efforts for antimicrobial stewardship were kind of like being the antimicrobial police, trying to take away or restrict the use of antimicrobials. Yeah, but what 30 years into this now, in terms of this field, the perception of this job amongst many stewards is changing. First, like stewards don't want to be the antimicrobial police for most of the cases. It's a very draining role. It led to a lot of people leaving the field. And often, there's a real challenge in terms of maintaining clinician autonomy because stewards are not directly taking care of patients, but also trying to help those clinicians make reasonable decisions. I share with you this screenshot from a presentation I gave in 2025 at the Society of Healthcare Epidemiology of America conference, which I will come back to later, where I asked the audience as an ID professional, so most of the people in the audience had some training or interest or practice in infectious disease. What is your one word stewardship identity? And you can see here, police isn't on there. Instead, it's communicator, educator, mediator, strategist, things that are not necessarily things that you're taught in medical school or in residency training, but things that are really important when you're trying to impact medical culture. So back to kind of my story and my sense now is I was drawn to antimicrobial stewardship because of the potential impact. As I mentioned before, my experience in global health and working in other institutions really led me to appreciate how important it is that the structure and I don't necessarily mean physical, I mean kind of the scaffolding of the medical system is really critical for effective clinician-patient interactions. And then as I've been in this field for over 10 years, I've really started to understand that stewards tend to have similar interests, and I've listed them here on the slide. This is what I tell many trainees who are considering stewardship, that if these are the things that resonate with them, maybe stewardship is a good idea for a career they could consider. One, stewards generally love data. We love to interpret data, both our institutional data. We have to be very good at trying to look at antimicrobial use data, but then turn it into a story that frontline clinicians and administrators alike understand. We're also really interested in staying up to date on current evidence. And in many cases, this has really been, I'll come back to this, has been really exciting because there's many more randomized controlled trials that help us understand the optimal management of common infections like pneumonia. So you have to be really interested in data, or at least my experience is stewards that really love their job are interested in data. You also, stewards that love their job just love solid clinical infectious disease and are as interested in the common infections as they are in the unusual infections. Because fundamentally, antimicrobial stewardship isn't trying to take away antibiotics that are necessary. It's just really trying to use antibiotics in a way that makes a lot of sense. So it's good medical care. That's fundamentally what it is. And then the third thing that I think leads to a very fulfilling and satisfying career in stewardship is for people that are very interested in behaviors. So we in stewardship need to understand and try to influence medical culture. Getting frustrated or irritated by decision making that we don't understand doesn't really serve you. Instead, it's really trying to understand what has led to a suboptimal antibiotic prescription or decision. The reason this is really important is that local prescribing culture is always super complicated. If antimicrobial use decisions that were suboptimal were only because of knowledge deficits, things would be a lot easier. But education alone usually does not change antimicrobial prescribing. And that's because all of these other things are contribute to why an antimicrobial is prescribed for certain circumstances. In very hierarchical healthcare settings, this idea that because my boss said so, or the senior doctor told me to do this and I don't have authority to question it, is something that we hear a lot about. But there's also a lot for clinicians about diagnostic uncertainty and this fear of omission, this idea that perhaps they're seeing so many patients they just can't think about particular antibiotic decisions thoroughly and end up leading to antimicrobial decisions that are suboptimal, lots of different things. So as a steward, you have to be really kind of an anthropologist and wanting to understand why certain things are happening at your institution. This has come to light in many different ways. We see this in our work at Stanford and also as our work in World Health Organization as a collaborating center, that the adoption of new clinical evidence really varies depending upon a medical culture. In this example, there's a lot of evidence, as you all know, that that antibiotics after a surgical incision site is closed are not indicated. And this is nothing new, but we can see in one potential like country and city that in one hospital, the orthopedic surgeons, for example, are 100% compliant, but the general surgeons are only 10% compliant. So it's the same amount of data, the same data, but interpreted differently by different people. And then in another hospital can be exactly the opposite. And the data is not different. The patients are usually not different, but the uptake of the recommendations is different, probably because of a lot of factors that have nothing to do with actual medicine. The other thing we really also understand in antimicrobial stewardship that's important is that clinicians' prescribing practices often depend on when and where they were trained. So this is one paper that's old at this point, but interesting in that a group in Canada looked at family practice clinicians. So this is really looking at outpatient antimicrobial use, and looked at how many of them prescribed long courses of antibiotics for urinary tract infections or respiratory tract infections. And even now, we think the duration should be 5 days or less for most of these things. And then they looked to see if they were early, mid, or late career. The axes here are proportions. So if there's a higher proportion of their prescriptions for respiratory or urinary indications were long, and you can see there's a lot more blue out here to suggest that practice really depended on when people trained. So again, evidence is not different, but the individual prescriber is. This is one example. There are many. I'm just giving you a few here, but this is another example of why it's where people trained is really important. So this is an example regarding antibiotic prophylaxis for extraventricular drains. These are drains that are placed when patients have interventricular hemorrhages or intracranial hemorrhages. And a survey went out to this huge neurocritical care society about their practice, because this is an area where there isn't a lot of data, but there's a lot of strong opinions. And the majority of the European respondents said, no, we never give prophylaxis systemic antibiotics for extraventricular drains. But then the majority outside of Europe, including a lot of respondents from the United States, said they did. And so this is there's nothing else that's different here except the individuals that are prescribing. Other things I've learned along the way of why stewardship is such a great career is that it allows for it allows for a lot of creativity and variety. I will say, and I can discuss later, that I think every single day my job is different. And every year my job has been different. And it's not because of what's on my job description, it's because of what's kind of going on and what we have decided to tackle. And I love that part of this work. And then I also love the fact that I get to work with a multidisciplinary team. I think for stewardship in particular, there's a really strong connection between clinicians and clinical pharmacists with training within ID or interest within ID. And that kind of um, unique collaboration has led to kind of a maximal impact in terms of what we're able to do in different healthcare settings. So I have to say, infectious disease pharmacists are some of my favorite people in the whole wide world. And so conferences education are starting to incorporate these new concepts. So no longer is training regarding stewardship primarily about how to manage certain clinical infections. Instead, curriculum is starting to kind of approach these stewardship leaders as needing a whole different skill set than ones that we may have attained in medical school and residency training. This is just one example from the SHEA, or the Society of Healthcare Epidemiology of America, stewardship course that I was involved in for a number of years. And in that case, our curriculum over a course of 3 days was designed to address three core parts of a stewardship's identity: the educator and the influencer, an antimicrobial expert, kind of being an expert amongst experts, and then being a leader. So the stewardship field is really evolving. This is part of why I love it so much. And it's a really exciting time for all of you who are considering getting into it. There's more and more data of how to manage common infections as it comes to in terms of duration of therapy, appropriate choice of therapy. There's a lot of interest in diagnostic stewardship. There's just so much more that we understand now about the management of common infections like community-acquired pneumonia, that make it easier actually to influence frontline prescribers. When you are the person who is bringing new data to them that will inform your practice, conversations go a little bit easier. There's also a lot more interest amongst healthcare professionals for antimicrobial stewardship. And I would say this evolution from being kind of the antimicrobial police to being more of a team member is a real part of that. And this is critical for the field. We need everyone to really embody antimicrobial stewardship. I start many presentations to frontline clinicians with a hand raise of like, how many of you consider yourself to be antimicrobial stewards? And then go on to demonstrate to them that in every time that they consider and then prescribe an antibiotic, core stewardship principles are critically important. This is one figure that really demonstrates just how important, at least in the US, that it is to us that other people adopt and just really make the application of stewardship principles routine, in that the number of antibiotic courses that involve hospitalists are much more common than any that ID specialists actually touch. And this is because of the management of common infections. So it's really important that we look beyond our kind of infectious disease borders. So I told you about two reasons why the field is really, this is an exciting time to be part of the antimicrobial stewardship field. And the third reason beyond data and more interest among healthcare professionals is that there's a lot more interest amongst patients about the harms associated with antibiotics. I think this will be really critical in turning the tide for antimicrobial stewardship. And this is really in part because almost on a weekly basis, there's more evidence about how antibiotics or disruption of our healthy bacteria can lead to catastrophic consequences. There's data now that links dysbiosis, or disruption of our microbiome, not only our gut, but we have the most information about our gut microbiome and how it impacts really critical clinical outcomes that matter to everyone, patients in particular as well. And that's really interesting, especially when it comes to response to cancer treatment or other treatments for metabolic syndrome. And then also something that's really devastating to many populations like neurodegenerative diseases. So because this has really started to permeate and there's a lot of interest in this, amongst clinicians, but also amongst patients, there's less demand. People want to be careful about the antibiotics they use. There are many times now that I have interactions with patients that maybe I didn't 10 to 15 years ago when they're like, I really don't want to have to take an antibiotic. And it's not just because of the diarrhea that they could have. Another thing that's really also interesting is that there's now data within the ethical fields about that optimal antibiotic prescribing isn't something we need to opt into or we can just decide we want to do sometimes. It's actually an obligation for clinicians under an oath that we all take about non-malfeasance. I point you to this particular article that was really interesting out of an ethical journal that was looking about a clinician's individual antimicrobial stewardship duties. And this group argued that the stewardship field has suffered from the fact that we're just trying to convince people to do this as something in addition to what they need to do instead of requiring people to do this. And they argued that there's enough data now, especially because of what we've long understood, that an antibiotic given to an individual patient impacts not just that individual patient, but the public and maybe their family, in that there's now data to suggest that a family in which one person in their household received antibiotics is more likely to be colonized with multi-drug resistant organisms, that there's a lot of ethical reasons beyond the big public health issues that we as clinicians have to be really careful about the antibiotics we prescribe. The other thing that's super interesting about the antimicrobial stewardship field is that we have also linked the fact that stewardship is also about reducing waste. There's a lot of interest amongst stewards to also incorporate kind of the environmental impact of antimicrobial use in the work that we do. And this, I think, comes into light really pretty directly with intravenous to oral antibiotic switches. There's a lot of reasons. I won't get into this. I'm happy to talk about it if you so desire, but there's a lot of reasons why we should be trying to convert patients from getting intravenous medications to oral medications in terms of length of stay and cost and lots of things we've understood for a long time. But now we understand that every IV to PO switch saves 20 minutes of nursing time in the era of nursing shortages. This is critically important, but also using oral antibiotics uses less generates less plastic waste and produces less carbon emissions. So this is just one example that I often bring forth. I just talked about it at a forum yesterday at our institution, that these are two common treatment options for community-acquired pneumonia. And just the simple decision to use Augmentin instead of ceftriaxone would lead to less plastic waste. Okay, so I wanted to emphasize maybe one more idea that ties into both like why I've found my career to be so fulfilling, and then also something that I'd really love to highlight for people going into antimicrobial stewardship is that every year, as I mentioned before, my job has looked a little different. Now, of course, my job looked different during COVID. I was working and supporting some of our infection prevention efforts. But I would say that every year I've done things that are slightly different. And one through line, although I've really enjoyed all the different varieties of work I've done at my institution, is I've loved working outside of my institution as well. These are three organizations for which I personally have really loved being part of different interventions. I'll talk most recently, I'm involved with the Society of Healthcare Epidemiology of America, which is an organization that's very interested in kind of overall improvement of healthcare institutions in the US, but also way beyond US borders. And I know um, I think the name actually is a misnomer in terms of the reach of this potential society. I currently chair the Antimicrobial Stewardship Committee, and some of the work we've done within this organization has been the most fulfilling in that it demonstrates that there's a lot of shared issues, and by working together across institutions, we can make a difference. Certainly, the Infectious Disease Society of America is another group that is very influential in terms of infectious disease professionals, in terms of career development. There's a lot of networking that's made. And over the next couple of years, I'll be leading the stewardship curriculum development for that conference. And then finally, the World Health Organization, as Dr. Mahar told you earlier, I'm the co-director of our World Health Organization Collaborating Center, and we've been working on projects since before I joined the faculty in 2015, including online courses, site visits, and some of this partnership is really, again, demonstrated. We have a lot of shared experiences in the antimicrobial stewardship field, and making connections outside of our institutions is really worth it in terms of trying to stay energized about your career and also bring back to your institution like, hey, this is what this other institution is doing. Do we really want to be left behind? I'll close with a couple of perhaps this is my last slide and we can move on to questions. But um, one thing that our stewardship committee focused on over the course of the last couple of years was updating this particular document, which is a guidance for the knowledge and skills required for antimicrobial stewardship leaders. This was a collaboration amongst multiple different societies, as you can see here. And this current white paper kind of outlines how many different things a clinician or a stewardship leader needs to become proficient and work on in terms of making an impact. And so I encourage you to take a look at that, and we'll be doing more webinars and promotions about this. But this is really about person and field development. Really big critical components, I'm happy to talk about this more, that are important for, I think, everyone's career development, but mine in particular was mentorship. But I would also say peer mentorship is really important. The stewardship field is great about this. When I've been approached about potential leadership opportunities, I have reached out to my stewardship collaborators and colleagues at other institutions to be like, what do you think about this particular thing? And I've really, really appreciated that. So I encourage you all to also start to develop your network. And then I think sponsorship. Sponsorship is underappreciated, and this was really important for me early in my career. And this is people who put me in front of them at our institution and outside of our institution to say, I think you should be the person who speaks at this particular forum, or I've thought of you for this particular role, and that has been critical. And I'll also just point out that I really encourage people at all different stages of their career to look for leadership training. This is not a one and done thing. I would consider these things as ability or opportunities to kind of invest in yourself and make time to really think about where you are in your career and what you want next. And so I've participated in several of these that have been really foundational in my career and in my role as Senior Vice Chair of Clinical Affairs for our Department of Medicine. I really look forward to promoting more of this. For me, as Dr. Maha mentioned earlier, mentorship and developing other people is why I do the work. I think, as I say many times, I'm here for the humans, and that means I'm here for the prescribers and for the people that want to do this work. These are all different people that are parts of our team that make the work, for me, really fulfilling. and a lot of why I love what I do. So I'll stop there and I'm happy to answer any questions and hear your comments.
Wonderful presentation. Wow. It's funny because every speaker that has showed different points, aspects of life, and I loved your story. I will start with a question that I like very much this. My job has looked different every year. And
Hmm.
sometimes, people think that antimicrobial stewardship is boring, is all the
Hmm.
same thing. And I love it to see different aspects that you pinpoint for us. I
Hmm.
know that it's really difficult to predict things, but um, the question that I received that I will add in the chat, how do you
Hmm.
envision the field of infectious disease evolving the next decade, particularly regarding education and research? And I'd like to add, like, regarding, I made a lot of notes here.
Yeah.
It's important data. And now we have large language models, you have artificial intelligence.
Hmm.
How can we envision this for the next years or decade, adding the artificial intelligence in our field?
Yeah. I think it's really, really critical questions. So many different questions here. I think so. First, I'll just answer it maybe in three different ways. But first, for stewardship, I've thought about this quite a bit. I think in general, we have focused in the stewardship field on inpatient settings, but 95% of antibiotic use for humans happen in the clinics. And so I think really the stewardship field needs to transition and move to trying to improve antimicrobial use in the outpatient setting. And that is going to take a real influx of new creative thinking because we have learned a lot about what works in the inpatient setting for antimicrobial stewardship, but we're not quite sure what works in the outpatient setting. And like for in the US in particular, a fairly significant amount of antimicrobial use is prescribed by dentists. Now, they're not part of the conversation for antimicrobial stewardship. There's a lot of interest in doing One Health, right? And thinking about ways that we can partner more with agricultural groups. So there's so much. I think the message I have for stewardship is I think that the field is going to continue to grow, needs creative minds, and needs a lot of iteration. And that's part of why I think that it's a great time to join. I think like the pendulum is starting to swing towards there being a lot of interest. For infectious disease in general, we're facing some really critical challenges. Cannot, I will not undermine that. I think certainly we've seen less people want to go into this particular field for a number of different reasons. And that's part of why I started with this saying that I think there's so many different things that you can do in this field. One thing that was really that I underappreciated going into it was how critically important stewardship or infectious disease clinicians can be in leadership at institutions. We end up knowing everybody. Like we know all of these different surgeons and in hospitalists and primary care doctors, and we know all these people because they refer patients to us. We're involved in really critical issues like outbreaks. And so I think we need to work on our leadership capabilities so that we can start to lead the healthcare system more effectively. Um, so I think leadership is one thing for sure. I think one really interesting thing about AI actually, there's a number of things I would say short and long term about that. One, we've been playing around with some of the different um, um, different platforms, trying to test out to see if they're all stewards. Because you can imagine if they're trying to please the person asking question and a patient is asking about sinusitis or whatever, you definitely want as patients start to use these agents more and more to help them understand their medical problems. We want there to be kind of a stewardship line. So that's something we'll have to keep our eye out on. But I think in a lot of ways, for stewards, we want to harness AI to help us with our day-to-day activities. I think we we often are under-resourced. There's few people trying to do lots of different things, so there's probably lots of ways. There's this kind of critical point that we're trying to get to of maximizing the utility and minimizing the harm, right, associated with using these agents as they are developing faster than maybe we can understand how best to utilize them. Um, I think the funding issue is a really large one, large, big issue, and it will take a lot of um, critical lobbying from our organizations as well to continue to support funding for really critical clinical trials that we need. I think the SNAP platform that's looking at lots of different questions related to Staph aureus bacteremia is really critical and has demonstrated like how to do things kind of in an efficient way. So I think we really do need more data to help us make decisions that will impact our patients. So to be honest, I feel fairly hopeful about all of this, despite everything that's happened in the last few years. And I would say that we have a lot of work to do, but we also have a lot of creative, passionate individuals that are willing to also do the work. Perhaps the last thing I'll say is that we learned a lot if you look back at early phases of the HIV epidemic in the US. Critical things happened because of partnerships with patients and patient advocacy groups. And I really wonder, some of these things is going to take more than our field to make a difference. And so being able to communicate with the public about how important this work is something that we also all need to do, in addition to being a steward with every
Oh,
antibiotic
yes.
prescription.
No,
Long
wonderful.
answer. Sorry.
No, but I totally agree with you. AI will have an impact in our lives, and as ID physician, totally agree with you. Yeah, but I think that you explained very well, and in your presentation, like that the IG physicians or IG people or antimicrobial stewards, they have different skills: communicator, educator, innovator, mediator, negotiator, strategist, and maybe we need to know how to manage these large language models. And I loved how you explain about the clinician autonomy. How can we preserve it? And
Yeah.
maybe that will be the challenge because sometimes we
Yeah.
are thinking about patients using AI, but the clinicians they are using against us. I don't
Yeah. I
know.
think that's right.
I
It's
don't know.
yeah, it's really interesting. I think, um a new issue that stewards, maybe all educators really have to contend with now is te learning and teaching our trainees how to be suspicious of what the response is from different AI agents. I think there's a real issue, right, is that everyone knows how to do Google searches or whatever, but you can't just do that with any of these because how you formulate your prompt really impacts the response. And that is a difficult thing when people are trying to move really, really quickly. I also do think as educators, we have to be humble because my kids are my kids are 12 and they know how to do things that I don't really know how to do. And so
Mhm.
this new generations they're going to understand things that it'll take us a while to get our heads around. And so maintaining the kind of the humility about it is also pretty important. Um, but I have definitely had experiences, and as I'm sure many of you have as well, where maybe a clinician has used AI to try to answer a particular question, and they get a wrong answer, and they just accept it wholly. And that's
Yeah,
always problematic.
I
Always
agree.
problematic. Yeah.
I have a question from Francisco. What is
Mm.
your experience with stewardship in patient seen by telemedicine,
Oh,
telehealth?
great question. Yeah, I think it's very interesting. This, I think, we could talk about for an entire hour, but
Mhm.
there's telemedicine within institutions, right? In which clinicians see the same population of patients, sometimes by tele and sometimes in person. And that practice hasn't been very different, at least in our experience. We haven't seen what we worried about, like more antimicrobial prescriptions for patients seen um, by telehealth versus in person for like a, a particular upper respiratory tract infection. And a lot of that is because of appreciation of just in case antibiotics are probably more harmful than good. But an area that we don't understand is more of the fee for service um, platforms, which really could be really impactful in terms of providing access to healthcare for individuals that have long wait lists or have insurance issues or whatever. But whenever there is not super, it's not clear who's what the patient satisfaction will really do. There's always this concern, right, that patient satisfaction drives antimicrobial use, and we know that's the case. We also know clinicians think their patients want antibiotics more often than patients actually want antibiotics. So it's all back to this very complicated culture. But when someone is paying to see someone online, um, it's certainly very different circumstance than seeing your regular doctor who is trying to kind of adhere to all the principles of their institution. I think this concept of maybe even like what we say in the US, the concierge medicine, or lots of other um, models which promise more access to patients, but then have a really complicated physician or clinician patient relationship are problematic. And I really think we need to keep our eye on it. Great
Great.
question.
We have a comment here from Tatiana. Tatiana is a pharmacist at Einstein. Amazing. I'm a steward too. It's inspiring to hear you talk about antimicrobial stewardship and your experience. Thank you very much.
Oh, I love it. Thank you, Tatiana.
There is another uh, question here from Francisco. We conducted a study here at Einstein where stewardship for antibiotic as a whole and for respiratory infections more specifically was better than in person. As the barrier to new consult is lower in tele, patients do not present as much resistance as in person.
That's
That,
interesting, right?
yeah,
Like
that's
how
interesting.
interesting. Very interesting. I hope you publish that
Yeah,
if you haven't already. I'd love to read it. But I think everyone's going to have very different because this is also as stewardship is kind of a young field, telemedicine is also quite a young field. So I'm very interested in everyone's different experiences.
yeah. We have people from the lab, and I have a
Mhm.
question here. How do you envision the integration of genomic sequencing and rapid diagnostic technologies transforming stewardship programs, particularly in identifying resistant organisms and tailoring therapy more precisely?
I think great question. Um, we have certainly experienced, I think the promise is huge here. I certainly one of the biggest issues that we have in infectious disease is we start with empiric antibiotics, right? They're our best guess. And so the more information we have sooner rather than later, when resistance could be really compromising our empiric antimicrobial choices is critical. So I think bloodstream infections, there's certainly been a lot of experience and data about how important it is to get um, rapid responses regarding the presence potentially of resistant pathogens. And the technology is pretty good. So I think there's a lot of great, there's great evidence out there for that as well. I think the where we struggle in some ways is things that are more complicated, like respiratory tract infections or the presence of pathogens in urine cultures. And in both of those situations, those are non-sterile sites. And so when you find different pathogens, potentially you don't exactly know if they need to be targeted with antimicrobials or not. And so those are situations where we have to be pretty careful. More data sometimes can be really difficult. We certainly know that clinicians have a hard time not treating a positive result. So, like a culture from asymptomatic bacteriuria of potentially carbapenem resistant pathogen could be a quote colonizer, but it leads to a lot of concerns about should we treat, should we not treat, and when it comes to things like that, where we know more antibiotics could lead to the emergence within that patient of more resistant pathogens, it gets really tricky. I think this has really come to light recently, even in pneumonia, where if you find respiratory viruses, does that mean you definitely don't need antibacterials? And you will see there's lots of different camps out there about that with data that's not great to help us make that decision. And that's probably because pneumonia is not just this one big thing. Instead, it's probably a spectrum of different diseases, but we don't have the tools yet to help us differentiate who needs antibacterials and who doesn't, who needs steroids and who doesn't. And so there's a lot we need to do. So I would say, um, I think there's a ton of promise in the field, and I really think that we need more evidence to help us know how to use it all um, most effectively for patient safety.
Wonderful. I'm not seeing any more questions or comments, but usually we have the opportunity for the speaker to give you your final thoughts before to wrap up the session. Please.
Well, I again thank you for having me. I would say if I haven't made the case already that stewardship's awesome, I hope I can underscore that again.
Sure.
Boring it is not. So, and I think the more we connect outside of our institutions, then you'll start to really feel the energy. So, the stewards at your institution, please reach out to me if you haven't already. We'd love to collaborate. And then I also would say that invest in yourself, like as you continue your career. I love Francisco's mentions of the work that they're doing at their institution, and tell us all of what you're doing. We want to hear about it. Um, and thanks for doing all the great work that you've done. And thank you so much for inviting me.
Thank you very much. Really appreciate. Thank you. Have a good
Bye,
day.
guys.
Thank you. Bye bye. Take care.
Bye.